Hello. Welcome to the, now it's kicking in. Welcome to our next speaker from the Collaborative Research Center for American Indian Health Pilot Grant Seminar Series. And as you know, we have been working through our pilot grants that were awarded in the first year of our grant, and are so glad that Dr. John Gonzalez from Bemidji State University could join us today and talk about his research. So it's my privilege to give a brief introduction for him, and then we'll let him take it away. So Dr. John Gonzalez is a member of the White Earth Anishinaabe Nation and an associate professor of psychology at Bemidji State University. He received his doctorate in clinical psychology, one of my personal favorite degrees, from the University of North Dakota. He is an alumni of Bemidji State University, where he received his undergraduate degree in psychology. Dr. Gonzalez's professional interests are in cultural psychology, multicultural psychology, and community psychology. All of these areas come together to provide a holistic view of people and their environments. Dr. Gonzalez's research interests are in the areas of mental behavioral health for Indigenous people and ethnic minorities. More recently, Dr. Gonzalez has investigated the racial experiences of American Indian students and Native peoples' racial experiences accessing healthcare, which you all know is an extremely important area, especially within our institution. So with that, I'd like to introduce Dr. John Gonzalez and his presentation, Is My Healthcare Making Me Sick? Microaggressions in American Indian Healthcare. I'll let you take it away. Thank you.
Kawai Mishomas Nokomas Nishinabe Dog, but we too much dumb indigenous Gawa Babi Ganikag in Donchiba. Thank you, Amy. Appreciate it. I wanted to first introduce myself in my native language, and there's a couple of reasons why I do that. One is that my dad always taught me that that's how you should introduce yourself when you address a group of people, and then the second reason is so that the spirits know who's talking as well too. So again, I appreciate the welcome. It's been a great day here so far, visiting with folks, and I appreciate you all coming. And for those folks who are online and out there in the world somewhere, thank you all as well too for signing on here. So. As Amy was saying, I was one of the pilot grant awardees, and got funded to do this project and looking at microaggression experiences in healthcare for American Indian people. And one of the things that I kind of want to preface is that initially I did some of this work with Native students on campus, looking at what the American Indian students' experiences were around race and discrimination. In the classroom and on the campus setting, and then during that process, I did some focus groups and things like that there, and then did a couple of other little small studies. But during that process, I heard lots and lots of stories from Native students that included experiences that didn't just happen in the classroom. They spilt out into the community, right? In terms of what their experiences were in the community. In everyday life, and then of course, health, accessing healthcare also was part of those stories that those students shared, in their own personal lives, but in terms of relatives and things like that there as well too. And then even personally, I know that I have some experiences of my own in my own family. My father passed away from complications of prostate cancer, and usually prostate cancer doesn't kill people. It usually, a lot of men will get prostate cancer, but they usually don't die because of the cancer. They usually sort of outlive the cancer and things like that there. But you notice that after he got diagnosed, and then through IHS and all that there or whatever, that it wasn't the best care. And he had lots of experiences around that and stuff as well too, in terms of experiencing discrimination in the healthcare system. So there's some personal and some professional reasons in terms of wanting to do this project, and they kind of were the impetus to going forward. And people in the community were talking about this a lot, so and I think it's important to the community as well too. So that's sort of my preface in terms of why I decided to do a project like this, and we're going to talk a little bit about in terms of what we found out as a result of that, right? So Of course, there's other reasons for that, and we all know. I'm assuming here in this room, and for folks who are out there who are signing in, that there are health disparities that exist, and American Indians, unfortunately, seem to be at the top of the list or the bottom of the list, however you want to characterize that in terms of the actual health disparities. I mean, American Indians, we experience some of the largest health disparities for almost every single preventable disease, right? So this is well known nationally, and I'm in Minnesota, so I'm going to specifically identify some of the ones that are in Minnesota that I'm aware of. And this data actually comes from the Minnesota State Health Commissioner's report that he actually submitted to the legislature about almost a year ago now, actually like in April or May of last year. This came out where they compiled all of this data and all this information and talked about health disparities that exist in Minnesota. And one of the interesting things, or one of the important things about that report that was submitted to the legislature is it was one of the first times that a health commissioner for a state actually specifically identified some of the inequalities that might lead to health disparities for different populations, right? So here's just a couple of the health disparities in general that exist for Native people in Minnesota. Not only Native people, but people of color. So you can see here, right, that African American men, black men die more likely from prostate cancer than white men. American Indians have, obviously much higher rates of diabetes. Latinos are also much more likely than whites to die from diabetes, strokes, and so on. Higher rates of obesity, breast cancer, and so on, right? So again, these disparities are out there. They exist. Here's another sort of a table that kind of, gives you some interesting information. So this is disparities in mortality for all death issues in Minnesota for that 4 or 5 year period there, and you can see that American Indians are actually at the top of the list for all of those age categories, although this one down here, you can see that, and I'm assuming that people recognize why, and it's kind of unfortunate, when you think about that, because we're dying before we actually get old enough to reach those years, because we're dying down here, right? More than folks by the time they get up there and so on, right? So that data is there. Here's one specifically for cancer, and you can see that cancer rates, have gone down in the years, but for black folks and for Native folks, you can see that, we still have significant, higher rates of cancer than the general population, than the other groups in particular there. And you can see that the disparity that exists between males and females as well, too. This one here is specifically looking at infant mortality rates. Again, these have went down over the years, and that's a good thing, but yet, again, black folks and Native folks are still at almost twice the rate of the other racial groups in society there, right? So we have significant numbers of infant mortality rates. Again, they've gone down, and that's really good, but, we're still almost at twice the rate and so on. I know that this graph here is actually really, really busy, but let me just take a little bit of time and sort of explain what the heck this is. So what this is a disparity ratio ranking here, right? And what's on this graph is about 16 different indicators of health and health issues that are tracked by the state of Minnesota. And it's a racial ratio or a disparity ratio where you take the lowest racial group and compare that to the highest racial group for whatever that health condition or whatever that reason for death basically is, right? And you look at the ratio, right? So the higher the number means, so for example, for homicide, American Indians are 13.2% more likely to die from homicide than whites are, right? So the interesting thing about this graph, or about this table here, right, is that American Indians are actually more likely to die or have this condition than any other racial group. We're the group who, for all 16 of these indicators, we have a higher likelihood of experiencing that condition or dying from that condition and so on than any other racial group in Minnesota, right? So, now this graph here in particular actually is very, very powerful when you think about this for a second in terms of what that disparity actually exists between American Indians and every other racial group in Minnesota. And I'm assuming that this would actually be very similar if we were to look at this nationally as well too, right? But so this is for Minnesota, okay? So again, this, there's lots of reasons why disparities exist. There's multiple reasons, and there's multiple factors in terms of why that exists. But this is what the health commissioner said about some of these health disparities, and he said that that your health, and of course he's not the first one to say this. Other people have been saying this for quite some time, but he said that your health shouldn't depend on how much money you make. It shouldn't depend on how much education you have, right? It shouldn't depend on where you live, right? It shouldn't depend on the color of your skin, and all of those different things, right? I mean, health shouldn't depend on those things, but unfortunately in our society it does, right? I mean, that table that I just showed you just a second ago basically speaks to that, right? That American Indian people, yes, we have high poverty rates, and we have lots of other issues that are affecting our communities, but that shouldn't determine when you're going to die. It shouldn't determine whether or not you get cancer. It shouldn't determine whether or not you get diabetes, right? It shouldn't, determine whether or not you have heart disease and all of those different things and so on, right? So there's these structural inequalities that exist in our society that contribute in a large part to these health disparities that exist out there. And one of those structural inequalities, or one of the ways that those structural inequalities end up manifesting themselves or end up playing themselves out, I'm proposing is through racial discrimination. And a lot of times it's sort of unconscious in these sort of implicit biases that people have that actually manifest themselves in terms of how people are treated, right? So this is where we get it, and I'm not the first person to say this, right? I mean, people have been talking about this for quite a while. The Institutes of Medicine, basically said this a decade or so ago, right? That, again, there's lots of reasons why, health disparities exist, but some of the evidence suggests that there's this bias, there's this prejudice, there's this stereotyping that's in the system that's, probably contributing to the health disparities that certain populations are experiencing. Okay, so with sort of having sort of said all that and kind of prefacing, this research, this is where we get into the discussion about racial microaggressions. And I know that this is a very busy slide, and you probably can't read that very well in the back, but that's okay. I'm just going to kind of walk you through this here a little bit. I feel like I want to move around, but I got this camera is like holding me here. It's all right. I won't leave you all out there. Okay. So, but basically, what this is this is a taxonomy around the issue of microaggressions, around this concept of microaggressions. Okay, and it was first obviously proposed and developed quite a long time ago, but within the last decade or so, Dr. Daryl Wing Su and several of his colleagues came up with this taxonomy and this language to talk about these very subtle forms of discrimination that people experience when you belong to a marginalized group in particular, right? So this one here is specifically talking about racial microaggressions, but anybody who, any marginalized group member can experience microaggressions, right? So this is a taxonomy specifically for racial microaggressions. You can see that there's different types of racial microaggressions. You have the micro-insult and then the micro-invalidation, which are often these unconscious ones, where the perpetrator is not even aware that they've committed a microaggression. In the middle there, you can see that there's micro-assaults, which is your good old-fashioned racism, if that language actually is right or not, but you know what I'm saying, right? I mean, this is your overt sort of, in your face kind of stuff or whatever. And then under here, you can see that there's different types of examples of what a micro-assault looks like or what a micro-invalidation looks like and so on, right? So for example, for a micro-invalidation, where when someone, espouses the idea of color blindness, the reason why that's a micro-invalidation is because it's denying a part of this person's identity. When you look at a person of color and you say that you don't see color, by saying that, I mean, on the surface, it's sort of saying, well, I see you as a human being and I treat everybody equal or whatever, but underneath that, you're basically denying a part of that person's existence, right? Because if you're a person of color, you grow up as a person of color. If you're black, you grow up as a black person. If you're Native, you grow up as a Native person. And you've seen yourself that way for your whole life. And other people have seen you that way and identified you that way. And all of a sudden that just sort of goes away. But, so that's why that's because it's invalidating part of your experience, right? The idea of an alien in your own land, this is most often thought about in terms of people who are Latino or Asian. They're considered foreigners, forever a foreigner, because they're not white, because the white is the standard or whatever. The Native version of this is actually really interesting in terms of how I saw this play itself out with students in particular, is where you're an alien in your own land if you're not on the reservation, right? If you're off the reservation, for some reason you don't belong off the reservation, and you're supposed to go back to where you came from, which is the reservation, right? So that's the idea of the alien in your own land, in terms of the Native version of that, in terms of what that looks like, right? So a lot of the microaggressions research that's been done in the past has primarily been done with African Americans and Latinos, and there's been very little research done with American Indians, okay? In general, right, in terms of microaggressions, in terms of, we've been talking about racial discrimination against Native people for quite a long time, but for Native people, specifically, in terms of using that language, it hasn't been used a lot and talked about. And then in the healthcare settings as well, too, it really hasn't been talked about or discussed. What it's been referred to, or how it's been talked about and discussed in the healthcare settings, is looking at perceived discrimination. That's the language that they primarily use. But perceived discrimination and microaggressions are very similar to each other in terms of the way that they play themselves out and so on, right? So they talk about perceived discrimination or racial discrimination in the healthcare setting. And there was one study that I was able to find that actually looked at this and did something very similar to what I was doing, and it was done back in it was published in 2001, where, in the King County, this is the Seattle area over in Washington, where they looked at racial discrimination in healthcare. And they identified, I'm actually just going to put all these up here and kind of just talk through these here a little bit here, right? So they identified several different, sort of areas or categories of experiences that people reported having when accessing the healthcare system. And you can sort of see them, right? I'm not going to go through all of these here. You can see that there was areas like differential treatment where people felt like that they didn't matter, or, they didn't receive the same care as someone who was, and most of the participants in the study were black. There was a few Latinos in there as well too, but they were mostly black in the study. So you can see that that they felt like that they were differentially treated, or people had negative attitudes when they did get treatment, or they were treated as if they didn't understand the ideas of health or what it meant to be healthy, or things about their own body. And you can even see where it gets all the way up to to where you're, again, this is your good old-fashioned racism right there, right, where people actually make racist comments or racist remarks, or imply that there's some idea of racist medical practice and patterns and things like that. There's a little video under that ghetto booty thing there. So I'm not going to go there and show that to you all, but if you just Google that, you'll find there was actually a news report that was done by CNN. Anybody here saw that before? Know what I'm talking about? Just let me briefly describe this, because it's it really sort of speaks to how a microaggression plays itself out, right? So there was a woman, she was a black woman, in, I think it was South Carolina or North Carolina, somewhere down there, went in to see a doctor because she was experiencing back pain, right? Lower back pain in particular. And she had some condition where you have, extreme curvature of the back, right? I forget the actual diagnosis or the technical term or whatever, right? So the doctor comes in and tells her, that, well, you have what we call ghetto booty. And she's like, what? Ghetto booty? And she was like, well, I don't even know what the heck that's supposed to mean or whatever, right? And it's, so then, of course, it caused, an issue and so on. And, she left her unhappy or whatever. And then that's how the news report got involved. There was a journalist who actually did a story on this on CNN. And then the doctor later said, I just tried to explain it to her in terms, that I thought that she would be able to understand. So, so you see what's happening here? So the idea was like, he basically, because she's a black woman, she wouldn't be able to understand what exactly this diagnosis meant if he used the actual technical language or the actual, language or, something about spinal lumbos. I don't know exactly. So there was an underlying meaning there, right? Is that, because she's black, that she wouldn't be able to understand, this medical terminology, but, she would be able to understand the idea of ghetto booty in terms of what that means, and so on, right? So if you want to see the whole story, you can Google that and sort of see whatever, But again, there's an underlying sort of, message and an underlying connotation there or whatever, where he just assumed something to be true or not true based on her race, right? So this was one study that was actually very helpful in terms of me developing, how to go about approaching this particular project with Native people, right? So some people might be asking themselves, okay, so what's the big deal about these microaggressions? Why are these, so problematic, and why are we even talking about them, and so on? What's the difference between this and your overt racism and so on? Well, the reason why microaggressions are a big deal is because there's these psychological manifestations and these dynamics in terms of what makes them a big deal, right, and why they're a big deal. And one of the primary ones is the idea that there's this clash of realities that exists. And what I mean by that, again, this doesn't even have to do with race. We can, again, any marginalized group member, right? If you belong to a marginalized group and you lived your whole life that way, right, you have a very different reality about what your experience is, right? So let's take race, for example. Okay, so if you grow up as a Native person or a black person or Latino or Asian or whatever, right, your ideas about race are shaped from your whole life experience in terms of what it means to be a person of color, right? And whites don't have that same experience, right? Nowadays, race sort of seems to be on the conscious of everybody, and we're talking about, we see these very sort of sensationalized stories about race and racism exist, happening in our society. So people are a little bit more aware of that or whatever. But honestly, for the most part, most white people never think about race because you don't have to. That's a reality, right? That's sort of the reality of growing up in a racialized society where privilege exists around skin color. And if you're white, you rarely ever think about race unless you hear it on the news, or unless you have colleagues or family or whatever who experience it and things like that. But for most people, they don't, and they don't have to, right? If you're a white person, you're just like everybody else, and that's what the norm is. That's what the norm in society is, right? Is to be white. That's the standard. Everything is compared to what it means to be white. But for people of color, every single day, we have to think about race. We have to think about, is something going to happen to me because I'm Native today? Is somebody going to say something because I'm black today? Right? That's the racial reality of people of color. If you're a woman, same thing. Women are marginalized in our society still, right? There's this idea of male privilege that exists, right? Women make 70 cents on the dollar compared to men. There's marginalization that women experience, right? And I'm sure that there's many women who wonder every single day, did that happen because I'm a woman? Did he say that? Right? Because of my gender? And men never have to think about that, right? Us guys never have to think about our safety, right? That's male privilege right there, right? If I'm at a party and I'm the only guy in the room, that's awesome. You know what I'm saying? Seriously, right? If you're the only woman at a party in a room full of guys, that's a completely different dynamic happening right there, right? That's a different reality. There's a clash of realities that exist there. For people of color and people who belong to marginalized groups, we can easily connect the dots from our whole life experience where whatever our marginalized group membership was impacted us. But for people who are not members of marginalized groups, you rarely, if ever, have to think about that, right? And it's harder for you to connect those dots. So that clash of realities is very, very powerful in terms of shaping our perception and how we approach situations and so on. And that's a big deal, right? And then there's this idea of this invisibility of unintentional bias and discrimination, which actually is part of the clash of realities in terms of how that shapes itself out, where again you have a standard, you have a norm that's sort of accepted in society, and that everything is sort of compared to that, right? And the whole idea of unintentionalness is actually important as well too here, where if I didn't mean to do it, then it's not that big of a deal, right? If that's not what I meant, people focus more on the intentions rather than the actual outcome, right? Or rather than the actual impact. Okay, so that's another, and then of course the catch-22 of responding. This one is actually a big one here. And what this is referring to, right, is that, okay, so you're a person who's just experienced a microaggression. And once that happens, your mind just starts rolling and asking yourself all these questions. Did I think what happened just happened? Did he really mean that? Or did she really mean that? What did she mean by that? Should I say something? Should I not say something? How do I prove it, actually? Because, of course, they can always deny it and say that they didn't really mean to it. So there's and then here's the catch-22 is no matter what you do, there's going to be consequences, right? If you don't say something, then you got to sit with that, right? You've got to go home, and I'll go home to my wife and I'll start complaining about this and start complaining about that and say, do you know who said, do you know what she said today? Do you know what happened to me today? And then I sit there and and it sucks up my psychological and my spiritual energy and all that or whatever, right? That's a consequence to me. But if I say something, then there's a consequence for that relationship, right? Usually I wear a lanyard, a key lanyard, and on there I have, anti-mascot button, right? That says, natives are not mascots, whatever, right? And I wear that every single day, okay? And I was in a meeting one time, and someone, brought up, said they were talking about baseball, right? And they said, those Indians beat the Twins again. And then someone said, well, those darn Indians. I was like, and these are my colleagues, right? So then, catch-22 right there. Do I say something? I got to work with these folks a lot. Or do I not say something? Do I hold it in to myself, And so there's always, there's this dilemma that we sort of experience, right? And then the last one is this perceived minimal harm of microaggressions, which is actually a microaggression in and of itself when you think about it. When someone, so say you call the person out and you say, what you just said there, was not appropriate, whatever. And then they come back and say, well, you're just being too sensitive. Why don't you just let it go? That's a microaggression in and of itself, where they say, well, it's not that big of a deal. Can't you just let, that's not what I meant. Can't you just let it go, right? I mean, this idea that, okay, that these things don't, have an effect over long term, right? So those are some of the psychological dynamics of microaggressions in terms of how they play themselves out, and then the reasons why they're a big deal. So why do I focus on microaggressions? I think here's a couple of things here. Let me kind of just walk through this here, right? Specifically in terms of healthcare settings, right? The idea that the patient and provider interactions are a possible point of intervention in terms of helping to deal with these microaggressions, or at least focusing on them, right? And the approach that I'm trying to take, sort of long term here, right, is this stress paradigm approach. We all know what stress does to the body. Well, I hope we know what stress does to the body if we're in healthcare, right? If we're doing research around health. I mean, stress is not good for the body, and it's not like major life events. I mean, yeah, those things are not good. I mean, but it's actually the daily hassles, right? Those daily stressors that we all experience actually do more harm than major life events do, right? And the argument that I'm making here is that microaggressions are one additional stressor that people who belong to marginalized groups have to endure. They're one added daily hassle that we experience on a daily basis, right? And and again, if these, and the idea here, right, is that they have cumulative effects on our health because of all those psychological dynamics that I just mentioned a second ago, right? Over time, they take their toll, right? And they can have direct and indirect effects on our health, right? If you're under high levels of stress, this can lead to things like hypercortisolemia and other issues, right, where your cortisol levels are always, up here, and that's not good, especially if you have other underlying health condition. I mean, someone who's got diabetes needs to keep that stress under control. Otherwise, it's going to lead to all kinds of problems, right? If you have heart disease, I mean, you don't want your cortisol, levels up here when it should be, down here, and it spikes when it's supposed to, or whatever, right? So it can have an indirect effect, but then it also can have an indirect effect as well, too. And I'm going to talk a little bit more about that in a second. But then for American Indians as well, too, one of the important things that we need to keep in mind is that the microaggression and microaggressive experiences also serve as an additional reminder to ongoing historical trauma and issues that we still, are struggling with as well, too, in our communities, right, around ongoing oppression and colonization and so on, right? So what's the evidence for what I'm saying here? Again, I'm not the first one to say this. Let me just put these up here and kind of talk through this. This is actually a model that was developed by Pascoe and Richmond that looked at perceived discrimination in health. Again, that's the language that they were using, but it's really, microaggression experiences. They did a meta-analytic review, and they talked about how perceived, can I move over here just a little bit here? This pointer here. Where perceived discrimination, again, microaggression experiences can have two effects, right, on two different types of pathways on mental and physical health, right, where it can have, it can heighten your stress response, right, elevate your blood pressure levels, elevate your cortisol levels and things like that there, but that it also can have another effect or an indirect effect in terms of modifying your health behaviors, right? And those things in combination can actually lead to health disparities, right? Where you have, and what they found, right, is that, higher perceived discrimination, was associated with more poor physical health, right? Because what happens, right, when you're under stress, we smoke more, or we drink more, or we don't exercise like we're supposed to, or we don't become active, or we eat things we're not supposed to eat, and all that kind of, that's an indirect effect in terms of changing your actual health patterns and things like that there, or whatever, right? It also was associated with poor negative mental health, like anxiety and depression. It actually can also increase the multiple forms of stress response. So again, I mentioned this already, things like blood pressure, cortisol levels, other hormone levels and stuff like that in the body. So they found, that there was evidence for these pathways to mental and physical health that were associated with perceived discrimination, okay? I have a few more here, but I'm actually just going to kind of, there's plenty of other studies out there that actually have looked at this and found these things to be true, where perceived discrimination was related to increased nocturnal ABP, is ambulatory blood pressure, because your blood pressure, we got health folks in here, right? Your blood pressure fluctuates throughout the day, and it usually goes up during the day, but it's supposed to, reset itself at night when you're sleeping, right? But people who experience more perceived discrimination or microaggressions, it doesn't reset at night. It doesn't come back down where it's supposed to, so it's sort of on a constant sort of hyper elevated level. I did a study, like I said, at campus, where I found that students who vicariously experienced a microaggression, meaning where they saw another student experience a microaggression on a video. So I did a little video vignette. I dipped into my screenplay skills here and wrote a little video where a student experienced a microaggression in the classroom, and other Native students watched this person experience a microaggression from a teacher. And then before and after, I took blood pressure levels, heart rate, and then measured their positive and negative affect and so on, right? And I found that there was an increased levels of, actually it's not blood pressure, it was actually heart rate levels. So there was an increase in heart rate from watching the microaggression experience of another student, and then also increase their negative affect and then decrease their positive affect. So that, gives us some preliminary sort of evidence, right, that not good, right? I mean, you all see what I'm saying here, right? So there's evidence out there, whatever, right? So, and I'm actually just going to skip over these. I'm sorry, we don't have time. And then I have a colleague who did another study at the med school over there in Duluth, where she looked at type 2 diabetes. And then within her study, she asked some of the participants and the patients in the study about their microaggression experiences in their study, right? So I want to actually jump to this because I'm getting ahead of myself here. So she had different outcomes that she measured in her study, things like heart attacks, that's the myocardial infarction there, history, hypoglycemia, the PHQ-9 is a measure of depression and things like that there, and then past year hospitalizations. And then she had, again, 6 items that, tapped into microaggression experiences. And a significant thing about her study that she did, and we actually just got this paper that I co-wrote with her. It's going to be published in the Journal of the American Board of Family Medicine, I believe is what that journal is. Should be coming out here in the next few months or whatever. And what she found in her study is that microaggressions were predictors of heart attack. So people who experience, these are all Native people, people who had diabetes in particular, who were getting treatment for diabetes, were more likely to have experienced a heart attack if they reported experiencing more of those microaggressions in their lifetime, right? And that's this one right here. You can actually see this right here, right? So this is a regression model here, right, where you can see that microaggressions were predictors of not only depression, but they were predictors of heart attack, and they were also predictors of hospitalizations in the past year as well too, right? So there's evidence out there that these microaggressions do have an effect and have an impact on people's health, right? Okay, so that sort of gets us up to sort of where, I'm just going to skip over this here as well too. Sorry. So that gets us to sort of where we are here with my particular study. And I think, am I running over time here? I think I need to kind of move on here a little bit. But so here's a pathway, between, stress and illness. This is actually a pathway that I developed initially working with Yupik populations up in Alaska, trying to identify what are the pathways to stress and illness in the study that I was doing with part of the Center for Alaska Native Health Research up in Alaska when I was working up there. But initially, it didn't include the microaggressions. So this particular pilot project was trying to answer some of these questions in terms of where do microaggressions play a role in here, and how are they associated with these different types of stressors, right? So people, come with all kinds of cultural and social contexts. They have major life stressors and things like that there. They have various coping responses and mechanisms and resources, how they perceive stress. Again, in general, right, what we know about stress research, it's not only the stressors, but it's how we perceive stress, right? Our perception of stress, plays a big role in terms of whether or not that stressor will actually have an impact on our lives, right? Especially our health, right? Because we all experience stress, right? Everybody experiences stress in their lives, but, we don't all have negative consequences as a result of that stress. So a big part of that is in terms of how we perceive that stress. Again, we have this indirect and this direct sort of pathway, or potential pathways in terms of, how we respond to that or whatever. So where does microaggressions influence this pathway, where and how? But then the other part of this, right, is that, what kind of microaggressions are Native people even experiencing, right? We need to identify those first, right? And then how often are they happening, right? So that's basically what the specific aims were of this project. The first one was, what are the types of microaggressions Native peoples experience when they access healthcare, so meaning who and when. That was one of the limitations of that study that I just talked about, the Mino-Giizhigad study, is that in there it didn't identify who committed the microaggressions. There was just these 6 items that people responded to, but it didn't ask who committed the microaggressions and where did it happen and when did it happen, right? So who and when is it happening? And then, do these things, impact healthcare utilization or health service utilization and so on? And how are they related to wellness and health, and how often basically are they happening, right? So what we did in our study is we conducted first focus groups to identify what are the types of microaggressions that people are experiencing, and then from that we developed this interview protocol, the assessment, and then we interviewed 50 patients, our community members, participants, to identify, okay, how often are these things happening, and then how are these things related to healthcare utilization and then a sense of wellness and things like that, right? So So that's the setup for the study here. So we did the focus groups. We actually conducted 4 focus groups with a total of 32 participants in those 4 different focus groups. And they were divided by gender as well too, because women, will talk about different experiences than men will talk about and things like that there. So here are some examples of some of the things that focus group participants said. So again, you can see this idea of differential treatment. The nurse acted like she didn't want to, touch me. You could tell she was uncomfortable being around me. This person was in a pain from a car accident. Had to wait several hours before they were able to actually get care or get treatment. The idea of negative attitudes, played itself out in the focus groups as well too, where you can see, just the way that people would, respond or talk to the patients. The idea of being treated as if they were dumb, and didn't understand or know anything about health and so on. This one here was actually really interesting, where the healthcare provider swore up and down that this, I think I got the percent sign actually backwards there, but that this, thought that this young woman was pregnant. And she's like, I am not pregnant. I know that I'm not pregnant. I can guarantee you 100% that I'm not pregnant. But they insisted that she was pregnant, insisted that she take a pregnancy test, and so on. And then, of course, later come to find out, that she wasn't pregnant. That she had another health condition, in terms of, so the idea that, that she doesn't know her body, her own body, in terms of, her, things like that. They're ignoring cultural values, the way that healthcare providers would respond to that. Again, the idea of inappropriate allegations, in terms of what that means and how it plays itself out there, right? And then, and then there was some, your kind of, micro assaults, I guess is the language we would use here, where, specific racial remarks or racist remarks and so on were made and things like that, right? So those are some examples. So out of this, we developed, again, we took those focus group data, did some qualitative analysis on this, identified, all of the different types of experiences that people had, and we actually identified 22 different types of microaggressions, and developed some questions around that. I'll give you some examples of those here in just a second here. So in terms of the interview protocol, this is what we administered to folks. So we got some demographic information there. The NPBI is the Northern Plains Bicultural Inventory. We have a measure of historical loss and grief there. This is Les Whitbeck's measure that, the COPE, B is the coping response resources, I think, and it's the brief version. The daily microaggression 10, this is what the measure that was developed by Karina Walters and her group over in Washington. Perceived discrimination scale, perceived wellness scale, and then traditional activity scale. Again, the 22 microaggression questions. And then we also had 2 open-ended questions at the end of the interview where we asked them, can you tell me about one of those specific incidents of those 22 that you said yes to? And then also, can you tell me a specific time when you had a good experience or a positive experience? What was it that made it positive or good for you as a Native person? So we wanted to hear about, what do Native patients sort of, think is, useful for them in terms of accessing healthcare, right? So that's the interview protocol. One of the things I also want to say, so here's actually some of the questions, again, of those 22. This is sort of how they were worded, and they were always worded with the preface, because you are Native or because you are American Indian, when seeking healthcare or medical services, have you ever been treated like a drug addict or like you were only wanting drugs and not really sick, right? Or because you were Native, when seeking health or medical services, were you ever made to wait longer compared to non-Natives? Or again, because you're Native, when seeking healthcare or medical services, did anyone behave as if they were uncomfortable or uneasy around you, right? So it was always framed in that way, right, in terms of the actual interview protocol there, right? So, okay. Questions? Comments? I don't mind. If people have comments or questions, feel free to chime in here and jump in, right? One of the other things that I actually want to just make sure that I mention in terms of the methodology here, I I went to each one of the tribes, even though I wasn't collecting data on the reservations themselves. I actually went to each tribe, White Earth, Red Lake, Leech Lake, to the tribal council and got letters of support or a tribal resolution from each one of the tribes to conduct a study. I also brought together an advisory board made up of mostly Native people. There was a few non-Natives on there. One physician from Sanford Health in Bemidji, Dr. William Dick sits on there. Dr. Valerie Fox was also on my advisory board, and I have a few other community members that are all Native that serve on my advisory board as well too, that sort of help guide this project and so on and so forth, right? So those are some of the methodology issues or concerns here. So in addition to asking about the microaggressions, we also asked, okay, who was involved, right? What type of medical or health or medical personnel was involved, and this is the response choices that they had to choose from. So ranging from front desk staff to, all the way even to security or somebody else, that's not listed there, and then where did it happen or what type of setting, and I have several different sort of possibilities here, right, in terms of as an inpatient, as outpatient, in-house service, clinic, doctor's office, emergency room, and things like that there, right? So they could identify, okay, who committed the microaggression and where did it happen and what type of setting did it actually happen and so on, right? So those are the responses. So here's what the sample looked like here. We did interview 50, but there was, for various reasons, sampling issues and response patterns, only 47 of them we could actually count in terms of our data, and you can see the breakdown there. In terms of education levels, 14 years about as was the mean. Employment, at least 60% of the sample of those 47 people there were working at least part-time. You can see the mean income level there. In terms of the main, I also asked them a bunch of, in terms of questions about their, their primary health concern right now that they're experiencing. So chronic pain, arthritis, lung problems, anemia, and blood pressure were the top ones that were listed by participants in the study in terms of what their current health concerns were at the particular time. Okay, so this Windows machine is throwing me off here, man. With a Mac, I can see what's coming next, so I want to. And then those slides are just too much hassle, so it's fine. We're going to roll with it here, right? So in terms of results, okay. So in terms of incidence rates, again, there was 50 people that we interviewed. 45 of those 50 people experienced at least one of those 22 microaggressions, right? So if you do the math, what is that? I mean, that's most of those 50 people that we interviewed experienced at least one of those 22 microaggressions, right? Again, about half of the sample, half of those 50 people experienced 10 or more of those 22 microaggressions, right? And then about 70% of the sample experienced at least five of those 22 microaggressions. So that tells us that that these microaggression experiences are happening a lot, right? Out of those 50 people. And then the recruitment for the focus groups were specifically, you have to be Native, you have to have obviously went to the doctor and experienced some racial discrimination, because we don't want people showing up to the focus group who've never went to the doctor, or at least didn't have no experiences around race. So for the focus groups, we specifically recruited for that. But for the interviews, it was just you have to be Native and had went to the doctor. And we didn't specify anything about, having experienced racial discrimination when accessing the healthcare, right? So I, that, again, kind of gives you more information in terms of how much these things are happening, right? They're happening a lot, right? Here, what I did was I tried to break it down here. I got a couple of little tables here to kind of give you a sense of the percent of the sample who experienced that particular microaggression, who committed it, and where did it happen, right? So the most common one that I thought actually would be drug addict, because that's what came out a lot in the focus groups, was actually not the most frequent microaggression. The most frequent one is where the provider had a negative attitude. So this one right here is actually the most frequently occurring microaggression experience, right? So where the healthcare provider, and you can see actually the people who committed it the most were the nurses and the front desk staff, and where it happened most was the IHS and when the person was an inpatient in the hospital, meaning they had to spend at least one night in the hospital, right? And then you can see that, where the person experienced differential treatment or they were talked down to. This is the example of the one young woman who was, told that, that she was pregnant when she was not pregnant, and they treated her like, she didn't know anything about her own body. That's the idea of sort of talking down to or whatever, right? And, where they were treated like they were wasting their time, are you really sick? This is not a big deal. Or they were treated like they were, dishonest, or they were lying. They felt like that they were, dishonest or lying, and so on, right? So, what else here? Questions? So again, you can, yes?
I have a question. So, was it microaggressions in the hospital over a specific time period or any time in your lifetime?
Yeah, so in the interview, we asked within the last 10 years.
Okay.
Yeah, so within the last 10 years, have you ever experienced, any of these situations? Yeah. So, yeah. Yes?
On the table, does each line go together completely? Like 55% felt being treated like a drug addict were by a physician at IHS?
No.
How?
Yes. Wait a minute, let me think about that for a second. Well, I mean, if you think of it, they must be, right? Because there was two questions, right? So they said, have you ever experienced this, yes or no? And if you said yes, then who committed it, right? And then most of the people said it was a physician who treated them like they were a drug addict. Where did this happen? And then the most common response was IHS. So then, then that makes sense, right? So you can see again, so this is just 11 of the 22 microaggressions in terms of what they're, again, the most frequent one was negative attitude and then felt like they were, dishonest or talked down to, right? And then on this one here, you can see that, how the other 11 played out. And this is actually the order in terms of how they were asked as well, too, from drug addict down to racial slur. And you can see these ones here occurred sort of at a less frequent amount, but still, there was, significant numbers of those participants who, experienced, where they felt like that the person inflicted unnecessary pain on them, or they made an odd comment about Native people, or they felt like that they were uneasy or uncomfortable around them. I call that the Indian in the room effect, right? Or the elephant in the room, nobody wants to talk about it, it's like there's this uncomfortable, easiness that people don't have a difficult time with that for some reason. This is actually one of the most common ones for students as well too on campus, is when there are only one or a few Native students in the classroom with 20 or 30 other non-Native students, and people are like uncomfortable for some reason. There's like this tension in the air that nobody wants to, I don't know, that's what I call that sort of effect, right? The Indian in the room effect, whatever. People just seem like uncomfortable, like, that I'm brown in this room with you or something. So that was the who, what, and where. Here's some of the descriptives of those other measures that we use. So AI cultural identification and white American cultural identification. So those things range actually from, from 15 to 60 is the range, right? Because there's 15 questions for American Indian identification, cultural identification, and there's 15 questions for white American cultural identification. It's on a 5-point scale, right? So it can range from 15 to 60, I suppose. So you can see the mean there was for each one of those. Historical loss is actually on a 5-point scale. No, it's on a 1 to 10. It's on a 10-point scale, right? And then historical grief, and there's two components to that historical grief for Les Whitbeck's measure, right? One of them is anxiety and depression feelings when they think about their losses. How does that make them feel? And then anger and avoidance is the other part of that historical grief. Those are actually on a 6-point scale. So you can see sort of what the mean there. The perceived discrimination is also that's on a 5-point scale. The number of microaggressions, so that's the mean number of microaggressions. So out of those 22, the mean was 9.27. Again, because there was 5 people who actually didn't experience any microaggressions right there. Perceived wellness was the measure that sort of tried to capture their sort of holistic sense of wellness, includes things like intellectual wellness, spiritual wellness, social wellness, actual physical wellness, and things like that there. And that ranges from, I think from what the heck is it, from 0 to 60 as well too. the Microaggressions 10 scale, and then within the Microaggressions 10 scale, there's a stress measure as well too, in terms of how stressful that was for you as well. So okay. So those are the descriptives there. You can see there's some key correlations that I try to highlight here with those particular variables. And I got these ones highlighted for a couple of different reasons here, right? So chronic pain was the most common health condition that participants reported experiencing, right? So I wanted to sort of see how these other variables correlated with that. And you can see, I have these ones highlighted here. Whoa. Whoops. I pushed the wrong button. What do you want me to do here? Go here? Right here? Okay. Oh, I got to click on it, right? Sorry about that, everybody. It's okay. Calm down here. So, I have these highlighted here because I think the strong relationships between the microaggression 10 scale, this is like a daily life microaggressions that you experience in daily life outside of health situations, right? It's so strongly correlated with historical loss, with historical grief, both in terms of anxiety and depression. And then over here you can see that wellness is very strongly correlated negatively correlated with historical grief, right? Whether or not it's anger and depression or avoidance, or anxiety and depression, or anger and avoidance, right? And then in terms of how that's related to chronic pain as well too. So there's an interesting manifestation that you can see within these relationships here, right? About how chronic pain, the sense of wellness, and then historical loss and grief seem to be very strongly associated with each other, right? And then how that also plays itself out in terms of the daily microaggressions that people experience in their life, right? So I'm gonna hope to make sense of this here in a second here, right? So with these relationships, in terms of looking at these relationships, what I tried to do was predict wellness and predict chronic pain based on these variables along with some of the specific microaggressions themselves. So I ran a few regression models to sort of test whether or not there's a relationship that exists here or whatever. So this is a regression analysis trying to predict perceived wellness. Again, this is this sort of holistic measure of wellness. And what I did was I entered in some of those other measures. Then I also entered in all of those microaggressions themselves, those 22 microaggressions. And you can see that historical grief, the anger and depression component of that in particular, the microaggression where they felt like they were treated like a drug addict, and then this coping response or this coping mechanism that people engage in, and then this specific microaggression about feeling like that they were insensitive to their cultural beliefs, were all predictors of of perceived wellness. And you can see the relation, in terms of the beta weights over there, in terms of the direction of those relationships or whatever, right? So whether or not a Native person has a sense of wellness, again, a holistic sense of wellness, is predicted by these kinds of microaggressions that they're experiencing, but then also in terms of their levels of historical loss and grief, right, that are associated with those microaggressions as well too. And then this active and social support coping mechanism is basically when they talk to family, they talk to friends, and all that kind of stuff there, or whatever, right? So that was one regression model that I ran, and then I ran another one, again, because chronic pain was the most common health condition that people reported experiencing. Again, I ran another regression analysis here, right, entering all of those microaggressions themselves, along with some of those other factors, and you can see here, right, that the number of health issues, obviously, that the person experienced was a predictor of chronic pain. So the more health conditions that they report experiencing, the more chronic pain. When they were treated like they were a drug addict, or whether they were treated as if they were dumb and didn't know anything about health. When, again, the Indian in the room phenomena right here, or when the provider had a negative attitude or a bad attitude, or when the provider even blamed the condition on their race or culture and said, if you Indians would just, follow my, prescriptions and do whatever you're supposed to do, then everything would be okay, and so on, right? So what this regression analysis, again, this one here, gives us information and sort of, kind of again, and you can see the significance levels there as well too, where these were significant predictors of whether or not someone was experiencing chronic pain. And I think what's important about this, sort of as a whole, when we're sort of looking at this, is this actually kind of goes along with some of the work that Karina Walters and others have been doing around microaggressions in general. And what they found was that that microaggressions, tend, and they were specifically looking at with the GLBT and two-spirited, populations that issues of historical loss, historical trauma, along with contemporary modern experiences of Native people, are manifesting themselves in the bodies of Native people in terms of the health conditions, but then around pain. They found something very similar to this as well too, that the more microaggressions that Native people reported experiencing in daily life, and then their measures of historical loss and grief, were predictable of whether or not that person would have a health condition and how much pain they were experiencing and so on. And I think that this actually, is important in terms of also providing us evidence around those sort of kind of issues and concerns, right? So in terms of future directions, one of the things I think would be important to do is a couple of different routes. One of them, looking specifically at patient-centered care and outcomes, doing some type of intervention around whether or not, we can provide more cultural training or things like that there to healthcare providers who are working with Native people, could be a way to go. Or another way would be looking at whether or not, how these things are associated with specific health outcomes like diabetes, cancer, heart disease, and things like that there, and so on. So, questions, comments? I don't know what slide's next, so okay, I've got to give acknowledgments here, right? So these, this study was, was the result of, funding through the, CRCAIH here, and the grant support that Amy's the PI on, and then the Mino-Giizhigad Study is also I talked about it, so I got to put that up there. How that goes. So, so questions, comments? Yes.
Well, I think it's very interesting and very good work. So that's the first one. I had a question. Did you notice any differences between the experiences of men and women in terms with the microaggressions? Just curious.
Yeah. No, I didn't talk about that, but I did look at that, and then there was no significant difference in terms of the number of microaggressions that men or women experienced. They're actually about the same. The means were about the same for each of them, and they were actually right around the mean, the average mean of 9. I think women experienced about 8 point something on average, and then men were like right around 9 on average. So there was no significant difference between the number. I thought there actually would be in the sense that women would experience more microaggressions. That's what I actually would predict, but there was no difference in terms of that specific, at least the number of microaggressions that they experienced. Yeah. Well, I figured that when being a double marginalized group member, right? Where the intersectionality of gender and race would lead to more, and plus what we know about Native women's experiences in general, right? I mean, so I mean, in terms of how they are marginalized in society and how they experience, significantly higher rates of sexual assault and abuse and things like that there, So I thought that they would be higher, but it wasn't. So. Yes?
I have a quick question. This is kind of back to the lit that you talked about, but is there any lit out there about the bystander effect on microaggression? So if people around the person being aggressed upon, I know that you talked about like the impact that can have on their stress, but is there any support or any lit on there about how they could maybe be a protective factor? Like if they're standing up or if they acknowledge the microaggression, how that would impact the person being aggressed upon?
Right. No. Yeah, so the question was, is there any literature out there that tries to look at if there's a bystander effect, or how whether or not if there's people who are present when a microaggression happens, what kind of mediating factor or what kind of influence does that have on the victim, right? That was the question there. And, that's a good question. I mean, I don't know if there's any literature out there or not, but I mean, I think that's interesting to think about how that does, or how that would either empower the victim in that situation, and I mean, I guess I would hypothesize that it would in some ways, because one of those folks might say something, you know, I mean, or you know, or speak up, or you know, or make a comment or whatever. So I'm assuming that it would, right? Yeah. I mean, I'm assuming it would have a positive effect on whether or not, you know, at least it would have. I think I would even go as far as sort of hypothesize they would also have a positive effect in terms of the impact of that microaggression, right? Where you weren't alone in that situation,
Like
right?
it validates.
Yeah, you know, there was somebody else who experienced that with me, so I can share that with them. So I mean, that might have some mediating effects in terms of the impact of the microaggression. But if that's where you were going with that, I don't know. Yeah. Other questions, comments? Anybody out there in cyber world?
Someone just asked if you could repeat the question.
Okay, so that works. Other questions? Yes.
So when you look at where interventions would be most effective, do you think it would be with the population that's doing the aggressing, or the population that is the recipient of the aggressing, in how to maybe advocate that sort of thing?
Yeah.
Bullying literature, and I think looking at Emily, that bystander has been seen as being a pretty effective intervention avenue when you're talking about larger wholes. So
Right. No, that's an interesting. Yeah, I mean, that would. I mean, I haven't really. I mean, I didn't think about it from that specific sort of angle in terms of, you know, working with, you know, the I guess the marginalized population in terms of how would you know, go about working with them to sort of buffer themselves from the experience of the impact of microaggressions. I was thinking more about in terms of the other side, right, in terms of perpetrators or whatever of microaggressions and you know, doing some type of intervention there. But I mean, that could be interesting. You know, I did another study, you know, prior to this, even prior to the microaggression study, where, you know, I looked at student success, and there was another set of sort of interesting relationships that I found where native students who talked about experiencing more perceived discrimination and had higher levels of historical loss and grief actually had higher GPAs. And I was thinking to myself, what the heck is going on there? I mean, that doesn't make any sense to me. Initially, I thought, I mean, that doesn't make any sense. I mean, are you saying that we got to discriminate against our native students on campus for them to be successful? I mean, that doesn't. But then I thought about that for a while, and I talked with a few people, and then the way that I interpreted that, right, is that, you know, these students are the students who actually know who they are, they know their histories, they know where they come from, right? They also have, you know, and those were the students who were actually more likely to also engage in traditional activities, and they were the students who were more likely to engage in sort of culturally specific coping mechanisms where they would offer tobacco, they would go to ceremonies and things like that. So I hypothesized that those were the students, as a result of sort of knowing who they were and their history and where they come from, they used that actually as a motivating factor. That I'm going to do good in school, I'm going to be successful so that I can, you know, go back to my communities. And so that might be sort of one way to sort of think about that, right, as well too. One of the things I actually didn't mention, and I want to mention real quick, and I know that we're kind of like, you know, short on time here or whatever, but you know, I wanted to also bring up those open-ended questions at the end, right, where we ask them, okay, what made it a positive experience for you, right? And there was a range of responses to that, and some from very, very simple responses, like the person who, you know, the nurse or the healthcare provider, when they came in or they greeted me in my language, they said bonjour, or they said ani, because most of these folks were native, or were Ojibwe, right? So when, you know, just the simple act of saying hello in the native person's language actually just diffused all of the tension just like that. So there's some, you know, so simple little things just like that, you know, where the non-native provider, you know, at least took the initiative to learn how to say hello in the native language. That was one of the main things that people said, all the way to where they talked about, you know, the role of like someone like Vicki Howard up in Sanford Bemidji, where they had a native staff or a native person on staff, either it was a physician or somebody who was there to provide support, you know, to me as a native person in the room. Also in terms of, you know, well, you know, the other comments were like, well, the physician, you know, actually specifically asked me about any, specific traditional medicines or ceremonies that might be, useful, that I might be, utilizing in addition to this Western medicine. So there was a range of, sort of things like that there that I think that, really speaks to the idea that when you're working with Native people, it's important to, for non-Native healthcare providers to really sort of, understand and think about the cultural effects and how that impacts Native people in the room and so on. So, other questions?
Join me in thanking Dr. Gonzalez for a great presentation.
Thanks everybody. Thank you. Micoraggressions.